This chapter we will discuss the Pontic design. Pontics replace missing natural teeth, where it restores the function and the appearance. It must be carefully designed to facilitate the thinning of the tooth and to prevent the plaque accumulation. Also to control the tissue surface around and adjacent the abutment teeth, which adjusts the existing occlusal condition. There are several types of the Pontics. Some require surgical modification because after the extraction of the teeth, the residual ridge got absorbed and the tissue also becomes less in its thickness. In most of the cases, it can be compensated with restorative options, but in some cases where we decide to do an implant, we use a hard tissue graft, or some soft tissue graft can be used. We will discuss the types of them in a bit. The first soft tissue technique is called the roll technique, where we get soft tissue from the lingual side of the edentulous side. The epithelium is removed and the tissue is thinned and rolled back upon itself, thereby thickening the facial aspect of the residual ridge. This is the roll technique. We can see that it can be used to residual ridge defect, and this is the place where here we remove the epithelial from the palatal surface of the defect place. Then the flap is elevated, and when we have a pouch on the vestibular surround surface, we roll the flap and do suturing here. Another technique is the interpositional graft. It uses a wedge-shaped connective tissue graft that is inserted in the facial aspect of the residual ridge. This is it. This is the graft. It is inserted and then sutured. When we need to increase the ridge height, we use the onlay graft. It is a thick, free gingival graft that is harvested from the palatal donor sites. Its survival is greatly dependent on the revascularization, which requires a preparation of the recipient site. So it is technique sensitive. This is the illustration of the onlay graft, where we get a recipient bed is prepared by the removal of the epithelium. Then we do cuts in the connective tissue to encourage the revascularization. Then the onlay graft is sutured in place. This is the procedure, and this is after the suture, this is after the healing, and this is the final result. After we do extraction, resorption in the alveolar bone occur. We lose 3 to 5 millimeters at 6 months after the extraction, and we lose 50% of the width of the alveolar ridge in 12 months after extraction. We can preserve this by immediate restorative intervention at the time of the tooth removable. We will see how. We do a conditioning to the site, and we prepare an abutment before the extraction as an interim abutment to preserve the epithelium of the socket. It should be an ovate Pontic. After 1 month of healing, a definitive restoration can be fabricated. Like in this case, the Pontic was inserted after immediate tooth extraction, and after we got the healing, the definitive restoration is being cemented although we usually get sufficient results, but the success is unpredictable because of the variability in the patient's healing response. Before the extraction of these teeth, we did an orthodontic extrusion of the two incisors, and we can see the difference in here to increase the gingival crest height. Then we added an interim restoration after we got the healing and the gingival contour. We did a definitive restoration. We will discuss now the type of the Pontics and their use. The saddle or the ridge lab Pontic has a concave fitting surface that overlaps the residual ridge. It must be avoided because it does not have an accessible cleaning with the dental floss, which lead to plaque accumulation and tissue inflammation. We can see this is a case where the ridge lab concave gingival Pontic was used and ulcerations were developed. We did a modification for this concavity and used this bridge as an interim restoration until the permanent one was being manufactured. After 2 weeks, the ulceration has been resolved. As for the modified ridge Pontic, it is the most aesthetic, where it does not require any surgical modification before the insertion, and it provides the ability to do the cleaning, which makes it tissue friendly. The sanitary or the hygienic Pontic, where there is no any attachment between the Pontic and the gingiva. It is usually in the posterior mandible region. It has a good oral hygiene but poor aesthetic. This is it, where we have the sanitary Pontic that is not attached to the tissue. Here, where it was close to it, the tissue had grow to close the space between the Pontic and the gingiva. The conical or the heart shape, it is not aesthetic, but it is good for the oral hygiene. So it is like the hygienist used only for the molars without aesthetic requirements. We can see this is its shape. It is attached to the gingiva with one point. The ovate that we discussed before requires surgical preparation to get the appropriate emergence profile. It is used for the anterior maxillary incisors, canines, and premolars. It is very high in aesthetic. The Pontic must allow dental floss to pass underneath it to get sufficient cleaning. Also, it must be glazed and well polished to prevent plaque accumulation. All of the materials that are used now, whether they are porcelain, zirconia, or metal, they are all biocompatible. Under the microscope how well polished and smooth they are. Some light reflection to get optical illusion and increase the realistic look of the Pontic can be achieved by monitoring the contour of the Pontic, also the inciso-gingival height, and we can see the difference between the two Pontics. The first premolar is less realistic because of its poor adaptation to the ridge. In the contrary, the second premolar is more realistic, where it reflects the light more uniformly, because there is a quiet adapted relationship, and there is no gap where the shadow can be formed, and we can see that there is a line between two different materials. At the end of the chapter, we will discuss two. As for the zirconia pontics, they can be used either anteriorly or posteriorly, and they show a high strength that can make them capable of tolerating the occlusal forces, but when other uses for the anterior zone, they must be veneered with a feldspathic porcelain for superior aesthetic results, and the color match the adjacent teeth. But the fracture of the porcelain layer in the zirconia is the most commonly observed clinical complication, but it is improved by the laboratory improvement processes with slow cooling that decreased this complication. To understand this, let's see how the zirconia is usually made. It is digitally planned and designed, then it is milled, and before the sintering, it is much larger than the actual bridge. We remove grind and sprue with the help of a round tungsten burr. Then we place it in the furnace and let it sinter as the instructions are being given. After it is completed and cooled, it gets to the appropriate dimension. For the Pontics and the fixed implant restorations, to get the best aesthetic results, we must have an immediate interim restoration to be placed in the implant place to provide support and shape for the soft tissue during the healing process and prevent the loss of the interproximal papilla leading to dark triangles. That's it. Salam.